hear me, okay? Okay, we'll talk about the bone tumors. We will talk about the generalities of the bone tumors and the benign bone tumors. And tomorrow you'll have the malignant one. For our plan is to discuss about the generalities, the classification, diagnosis, treatment, and then we will have the most frequent benign tumors, and we will discuss about each one. What's a tumor? A tumor is a tissue of no formation, and it is very important. The type of tumor it is in concordance with the origin cells of one or several tissues, depends of the type of the tumor. The appearance of that tumors is atypical. It has autonomous and without a finality if we don't make some surgical procedures that we will discuss. And it is very important. It is a progressive pathology. There exists some special types for benign tumors, some classification that slow autogenous growth. If we discuss about the benign tumor, it is typical. It is very important that because the malignant tumor don't have a typical growth, and in benign tumor we have a typical differential cell morphology, and it is very important for the benign tumor. It is an expansive growth with net shape and capsula. That's another sign for another specific sign for benign tumors. Other sign, it is no recurrence after excision, after a surgical correct procedure. In malignant tumors, we have the chance to recurrence after the excision, but in the benign one, in most cases, if we are making a correct surgical procedure, the recurrence after excisions could not appear. And don't make metastasis, don't make tumors on distance. For example, we have chondroma, osteoma, fibroma, lipoma, depends of the type of the cell that benign tumor are growth. The malignant tumor are fast growing, and it is very important that have an atypical cell morphology. If we are discussing about the benign tumor, we have typical cell morphology. In malignant tumor, we have an atypical one. We have an archaic tissue architecture, and that's specific for the malignant tumor. It is invasive and infiltrative growth, have no capsula. It is infiltrative, that it goes in soft tissues, it expands in all tissues between the bone. Local recurrence in the absence of wide resection and metastasis are the rule for the malignant tumor in comparison with the benign tumors. The tumors with low malignant grade. There exists some tumor with low and great malignant grade. It exists some cases that some tumors have some intermediate characters that we are discussing about a benign tumor that have an intermediate character and could be in time malignant tumor, and it is very important to put immediately the diagnosis and to put a correct diagnosis and to make a correct surgical treatment to have a success in our cases. Yes, we need a multidisciplinary team. It is very important that the surgeon discuss with the radiologist and with the oncologist for a correct treatment. The treatment for, especially for the malignant tumors, it isn't just the surgical one. We have to make some procedures, imagistic one, and we will talk a little bit about it. for example, the angiography and for embolization the tumors, to stop the cells goes in the blood and goes for metastasis, and it is very important to talk with the radiologist and to make some investigations after the surgery. Sometimes we need to make immediately some types of investigations and done to make the surgery. The oncologist, the radiotherapist, it is very important to speak with them and to make a team to put a correct diagnosis and to make a correct treatment. The gold standard for our diagnosis, to have correct and precise diagnosis, is to make the biopsy. Is the key capital approach. Could be negative or positive. If we have a positive diagnosis, we know what kind of tumor is. We know that is a malignant tumor or a benign one or a borderline one. It is very important to establish because the treatment is different. When we are talking with our patients, it is very important to know the history of the patient, the clinic presentation of our patient, to ask for imaging, if even it's an MRI, CT, X-rays, to make laboratory and to make some specific investigations, and then anatomopathology diagnosis. And it is very important because that's the final diagnosis. The classifications of our bone tumors, it is very important because it's different in comparison with other types of tumors. Good classifications should include our characters as histologically, clinically, radiologically, or imaging, even if it's we are talking about CT or MRI. We have to look intraoperatorily at the macroscopic aspect of the tumor and to establish a prognostic and to establish the type of treatment, even if it's just a surgical treatment, if we have to speak then with an oncology doctor. The notion of compartment and capsule, it is very important because that sign or that character for a benign tumor. The compartment, it is very important to establish that we have a lesion that it includes intracompartment lesion or it's an extracompartmental one. In malignant tumor, in most cases, when we are putting the diagnosis, we have an extracompartmental tumor. And the surgical procedure, it is in concordance with that type of compartment or extracompartmental tumor. In concordance with the histological classification, we know what kind or what type of cell we have to establish in our histopathology examination. For osteoid osteoma, for example, for osteochondroma or osteosarcoma, we have bone cells. For cartilage-producing tumors that we have in our histopathological examination, we will see chondrocytes, okay, in chondroma or chondrosarcoma. That's cartilage-producing tumors. Other types of tumors are represented by tumors with connective vascular tissue that we are discussing here about the hemangioma, lipoma, fibroma, or fibrosarcoma. That's malignant tumors that have the types of cells that we are seeing for normal in the vascular tissue. For giant cell tumor, for example, for tumors of bone marrow, like in reticulosarcoma, we are naming that type of sarcoma the Ewing sarcoma, lymphoma or myeloma. Other type of cells we have in pseudotumoral lesions that essential aneurysmal cyst, fibrous dysplasia, or recipient hematoma. And other types of malignant bone tumors could be secondary tumors. In that type of secondary tumors, we are discussing about the tumors that could have all the types of the cell from the primary tumor. It is very important because when we are making a biopsy on a secondary tumor of the humerus, for example, we know that we will find cells from the primary tumor. We will find there the histopathological examination tumors that are represented by the primary tumor. The classifications of musculoskeletal tumors, big classification include the benign tumors or malignant tumors. The benign tumors could be latent, active, and aggressive. Notice that it is very important to know that active and aggressive benign tumor are represented by the borderline tumors because could be in time could transform that benign tumor in a malignant tumor, and it is very important to establish rapidly the correct diagnosis and to make a correct treatment. For the malignant tumors, we have two types of tumors, the low-grade malignancy and high-grade malignancy. It is very important by the evolution in time and by the metastasis. It is very important to establish what kind of malignant tumor we have, the low-grade one or the high-grade one, because the treatment could be different and the prognostic and the evolution in time, it will be different for that two types of tumors. The most frequent for tumors, even it's a benign tumor, even it's a malignant tumor, we are using the Anaking classification. That's an important classification for us. It is different comparing to other types of tumors. And that's important for us because we are naming and we are knowing that about the topographic and prognostic of that type of classification. The surgical staging system. We have G, the degree of histological aggressiveness, and we are discussing the low-grade malignancy, high-grade malignancy to know what type of tumor what type of tumor we have, the regional development of the tumor, and M, the metastasis. We are including that three chapters in our classifications. What does it mean G? We have G0, 1, or 2. The G means the benign histological tumor in G0. In G1, we have the tumor with low-grade malignancy, and in G2, it is the most important type of tumor. It is represented by the tumor with a high degree of malignancy. What does it mean T? T0 means in situ tumor. It is a small tumor, but in type 1 and type 2, it is a big difference between type 1 and type 2 about the evolution of our patients, because in type 1 we have an intracompartmental tumor, but in type 2 we are discussing about the extracompartmental one. It is very important to establish because the chances of metastasis, even we are discussing about the skip metastasis, even we are discussing about the metastasis in distance, it is very important to establish the type of T. And M, we are discussing about M0, that means we don't have any metastasis diagnosis. Our patient, it don't have the diagnosis of metastasis in distance, and in M1 the patient have metastasis. That's the big class, the type of our big classification. We are including, according to Anakin classification, 3 type of stages for tumors. In type 1, we have G1, T1 or T2, we have M0. In stage 2, we have G2 with T1 or 2 with M0. But in stage 3, we are discussing at the B line at G1, G2, but with metastasis. It is very important. In stage 3, even it's G1, G2 or T1, T2, if we have an M1, it's stage 3 of according to Anakin classification. How is the appearance of our patient? How is the clinic of our patients? They have pain, tumefaction because of the extension of tumor. Tumefactions in most cases are represented by the extracompartmental stage, but could be in intracompartmental one. We have muscle atrophy because of the pain. Adenopathy, it is not most frequent in bone tumors. Why? Because we don't have that type of circulation for the bone, okay? And in most cases, we don't have adenopathy. It is very important to establish if we have a neurovascular injury. Why? Because in the time of the surgical intervention, it is very important for us for the bleeding, for example. If you have a vascular effect by the tumor, it is very important to know that and to know how to intervene in the surgery moment. And other type of clinic presentation of our patients are represented by the pathological fracture. If we have a pathological fracture, if it was an intracompartmental type of tumor, when we have a pathological fracture, it is for sure that now it's an extracompartmental type of tumor. The pain, in most cases, it is the first sign. How appear that pain? By the compression, stasis, hypoxia, could be like a discomfort or could be a localized pain, a localized night pain. For example, in the most frequent cases of osteoid osteoma, we have night pain. Tumefaction, it is represented by the pedicle tumor, soft tissue invasion, characters, constancy, and adherence, and infiltration. In most cases, in that type of infiltration, it is most important because in most cases we have an extracompartmental type of tumor. That's an image, that's an example for a bone tumor on the forearm, and you can see very good the tumefaction in that case because of the infiltration of the tumor. The muscle atrophy are represented by the pain, by the antalgic, and in most cases, when we are not putting immediately the diagnosis, could appear that muscle atrophy secondary to the antalgic play. We discussed about adenopathy. It isn't represented for the bone tumor, but the neurovascular lesions are very important for us because we have to make some procedures preoperatively to make an embolization for that type of vascular lesions of the tumors. In most cases, we are talking about malignant tumor, not benign tumor. In benign tumor, we don't have infiltration in the vessels. Why? Because we discussed that the benign tumors have a capsula and are very good represented by that capsula, and no infiltration in the soft tissue, in the muscles, in the vascular tissue or neural tissue. And it is very important. That's a sign in most cases for the vascular lesions. That's a sign in most cases for malignant tumors. That's an example for an osteolytic bone tumor of the middle part of the shaft of the femur, and you can see it appear a fracture on a pathologic bone. In the second image, we'll see a comminuted fracture with a big osteolysis on the shaft of the femur. And here we have another example for osteocondensation lesions. You can see here, you can see here, and it is very important to see that fracture on a pathologic bone. All right, for the diagnosis, we have the conventional X-ray to make the X-ray in more than one incidence. Why? Because to make a 3D view of the bone and to see all of the types of the bone lesions. The X-ray is the standard method for assessment of the bone tumors. Why? The answer is because it's rapid, with low cost and the base spatial resolutions. But for that base spatial resolutions, you have to make more than 2 X-rays, okay, to see an anterior view, anteroposterior view, or lateral view to make that 3-dimensional view to put a correct diagnosis. You can see the lesions of the bone, you can describe the lesion, you can tell us about the osteolysis or osteocondensation. Okay, the cortex in bone tumors, and benign one, the cortex is skipped, the demarcation for the surrounding bone, the marginal sclerosis, without affecting of the soft tissue. It isn't that correct because you cannot see on the X-ray the soft tissue. For the soft tissue, you will have to ask for the vessels, for the muscles, for naming the type of the tumor. If it's an intracompartmental one or extracompartmental one, you have to ask for MRI or you have to ask for CT. But the cortex, the demarcation bone form, and the marginal sclerosis, you can see very good on the X-rays. For the malignant tumors, the cortex are disrupted, are imprecise delimited with a transition zone, peritumoral soft tissue opacification, and periostal reaction. The last sign, it is very important and it is most frequent, and it is very important to recognize on the X-ray or on the CT scan to make a diagnosis between the benign tumor to malignant tumor. In malignant tumor, in most cases, you have a periostal reaction. In benign tumor, you don't have the periostical reaction. If in just one case, if it's a borderline tumor, that it was a benign one and now it's a malignant one. But that's a specific sign for the malignant tumors, the periostal reaction. That's an example for a benign tumor and comparing to a malignant one. You can see a very good demarcation. The periost is normal, is not interrupted. Okay, it is like a cyst. It is a very good demarcation here between the normal bone and the affected bone. In this case, you cannot see the demarcation between the normal bone and the abnormal bone. You can see osteolysis, you can see osteocondensation, and very important, you can see here a disruption of the periosteum. And it is very important because that's a sign for a malignant tumor. Where can you see the periostal reaction? On the lateral cortex, sorry, here is the periosteum and here is the reaction. Do you agree with me?
Yeah.
I have a question. Could somebody told me what's that? That's a humerus. That's a bone tumor on the proximal part of the humerus. That's glena. And could anybody told me what's this?
Head of the
Sorry?
head of the humerus.
Head of the humerus, but it's, you can see here it's normal, the head of the humerus, and here we have a disruption. What does it mean, that disruption? I will help you a little bit. That's a child.
Growth plate?
Yes, and that's adult. Okay? Okay. On conventional radiography, you can see the periostal reactions. In some cases, for some types of tumor, for example, for Ewing tumor, you can see the sign of onion bulb, and I will show you on X-rays. You can see some specular of the periosteum reaction, that's like a grass fire. It is specific for Ewing tumor, that's malignant one, or periostal spars, death triangle of the Kottmann. And I will show you on X-ray what's the Kottmann triangle, and that means it is an aggressive tumor. You can see here a triangle of the periosteum reaction. Other image, the triangle of the Kottmann. You can see here a big tumor, that's an extracompartmental one because it goes in the soft tissues. You cannot see very good the lesions of the bone, but you can see very good the reaction of the periosteum here, the Kottmann triangle, the triangle of death. That means it will be an aggressive tumor, not just a malignant tumor, it is an aggressive one, and in most cases it have a don't have a good evolution in time, and in most cases we have metastasis in distance of that type of tumors. Other sign of periosteum reaction. Okay, the CT scan are very important for us, give us very important informations for the cortical lesion, periostal ossification, vascular trunks view, and it is very important because in that type of investigation we can see vessels and nerves, and we can establish if the tumor are affecting that structures and the muscles and the soft tissues, and it is very important to make for all the patients that kind of investigation. It is very important because you can say then the relationship with the structure, vessels, nerve, viscera, joint, cavity, and medullary channel. In time, you will see the patient, and you will have to make annually that type of investigation after the surgical procedure. And in most cases, we are making the CT scan after 6 months, and then every year to see the local recurrence. It is very important. And other important of that type of investigation, it are represented by the method of choice of intracortical lesions. You can see here the discrepancy between the X-ray and between the CT scan. You can see here it is a lesion, probably we have osteocondensation on the proximal part of the tibia. It is a pathologic bone. We have a lesion that it is for 2 or 3 centimeters on the X-ray, but you will see very good invasion on the CT scan, that you can see it is bigger than the tibia, the invasion. It is a big one. It's an extracompartmental type of lesion of a malignant tumor. There exists a discrepancy between the X-ray in most cases in comparing to the CT scan, and it is very important to use X-rays to see the type of the tumor, to make a lateral view, to make an anterior view, to make that 3D view. But then it is very important to ask for other types of investigation to see the extension in the soft tissue, because on the X-ray you will never see the soft tissue extension. You can tell me, yes, it is a soft tissue extension, because we are saying here that it's not just affected the bone here and it goes from soft tissue, but here you can see the soft tissue affection, and you can see the vessels and the nerves, and you can make a correct planning for a surgical treatment. Other type of tumor, that's a benign one. You can see here a very good delimitation between the normal bone and the abnormal bone, the pathological bone, and you don't see any periosteal reaction. But on the CT scan, you can see that little image here. Here are the intramedullary canal, duct, okay, and here you can see something abnormal on the cortical part, an osteolysis, and then a small osteocondensation. That's a specific image for benign tumor for osteoid. The diagnosis of MRI, the best method for evaluation intraosseous skip metastasis and extraosseous extension, and we are speaking here about the soft tissue extension. You can tell me then, after the MRI, you can tell me the relation with neurovascular axis, and you can use contrast substance to see very good the vessels and the invasion of the tumor in that. That's an example for an MRI. That's an example for all the muscles that are here, from the gluteus, iliopsoas muscle, and all the muscles that have insertions on the proximal part of the femur that have a tumor invasion after chondrosarcoma. It is very important to make that kind of images. Other example, discrepancy between a lesion that we are seeing on X-ray that's osteolysis. You can tell me that it is quite good delimited the affected bone in concordance to the normal bone, but when you are looking at the CT scan, at the MRI, you can see the invasion of the soft tissues here, and it is very important to see that, because in that image you can tell me that it's an intracompartmental type of extension of type of tumor, but if you are making the MRI, you can establish, and you should establish, that it's an extracompartmental type of tumor, and it is a high probability to have a malign tumor. The scintigraphy, it is another very good investigations for us, and we are using in most cases of tumors, in most cases of malignant tumors. Why? Because after that type of investigation, you can tell us if it's a polycystic or monocytic tumor, and it is very important because you have to treat all the tumors. You can see very good the metastasis, for example, for the sarcoma, and it is a very good investigation for a postoperative monitoring, even a local type of the tumor or metastasis at distance. Why? Because for normal, after the good treatment, a surgical one and oncology treatment depends on the type of the tumor. After that, you are making the scintigraphy, and it is a metabolic inactive lesion. If we have a metabolic active lesion there, it means that you have a problem, and you have to check for recurrence, even it's a recurrence on the site of the tumor or in distance. That's an example for our scintigraphy. You are seeing the anterior view in the first image and the posterior view in the second one. You will see that in that case you are having a lesion that's in the anterior part of the tibia, on the proximal part of the tibia, but you have many lesions that are metabolic active, and it is very important because you have many tumors. What does it mean? It probably means that you have another tumor, another one, a cavitar one, for example, and that all that modifies of the bones are represented by the metastasis. Never ever a bone tumor goes or makes metastasis in distance. The primary bone tumor we are speaking here, not the secondary one. The primary bone tumor don't give us metastasis on distance. And if you have that type of many lesions of the bones, it could be, all of that could be metastasis, but you can make a biopsy there, for example, on the tibia, and then you will find cells from the primary tumor, the cavitar one, for example. That's another example for many metabolic active lesions of the skeletal. Other investigation that we are using is arteriography. It is an investigation, and it is for treatment too. Why? It is very important because we can make selective embolization for preoperative hemostasis. That's very important because making that's an image of arteriography. That's an image when we are making the arteriography, and you can see that here we have a pedicle and we have a very good vascularization on our bone tumor. After the embolization, you cannot see anymore that very good vascularization. It is very important for two criteria. One of that, it's you reduce the bleeding on the surgery procedure, and it is very important by making that embolization. And the second one, you prevent the skip metastasis in the blood, and it is very important that too. And we are using, in many cases, we are using that type of arteriography. For some types of tumors, are represented by laboratory modifications. Increased ACR, sedimentation rate, and the CRP are specific for Ewing sarcoma or lymphoma, but could appear in other types of bone lesions, for example, in infection. Other types of laboratory abnormalities, it is represented by increased alkaline phosphatase that appears on osteolysis of the bone. Could appear in bone tumors that have on X-ray or CT scan the osteolysis aspect. The increased acid phosphatase are represented in the condensed metastasis, for example, in the prostate carcinoma. The LDH in Ewing tumor, and for example, the monoclonal protein in plasmacytoma. That are specific for some types of tumors, but you cannot make, or you will be not able to put a correct diagnosis by making just that type of laboratory diagnosis. It is very important to make the biopsy. That will be your final diagnosis, and that will be the time that you are making your surgical procedures, your preparatory planning for the surgical procedure. It is the types of biopsy, including the incisional one, the biopsy puncture, depends of the type of the tumor, and more important of that, it depends of the localization of the tumor. But it is very important for all the type of the lesions, even if you think that after all the investigations, if you think and feel that you have a malignant bone tumor or a benign one, it is very important to make that biopsy, even it's an incisional one or biopsy puncture. It is very important to make that, to have a correct and complete diagnosis, to know what's the correct treatment for that patient. The treatment. What's the treatment in our cases? It is very important. The treatment, it is according to the type of the tumor. It is very important to make a biopsy, and then it is very important to establish the type of the treatment. The surgical treatment could be intralesional, marginal excision, intracompartmental excision. That's just for the benign tumors. For the malignant tumors, you have to make a radical, an oncological surgical treatment, and it have to be extracompartmental excision. Because if you are not making that, the recurrence of the tumor, it will be the rule. For example, the radical type of surgical treatment are represented by the extracompartmental surgical type, and you can make them reconstruction with tumor prosthesis, with big prosthesis that are specific for that type of treatment. For the benign tumor, you can make that marginal or intraregional surgical treatment. The chemotherapy could be pre or post-operative. It depends of the type of the malignant tumor. It exists some substance that we are using, but you have to know that the chemotherapy and the radiotherapy for most bone tumors are not an efficient treatment. The most important treatment is a correct resection of the tumor, extracompartmental one, to reduce the skip metastasis. It exists just one tumor, the Ewing one, the Ewing malignant tumor, that have a good response on the radiotherapy. But in other cases, the radiotherapy, it is not efficient in our treatment. The gold standard treatment are represented by the surgical intervention. We will discuss about the most frequent benign tumor today, and tomorrow in the next course we will discuss about the most frequent malignant tumor. We have to know the characters of the benign tumor and to establish on the imagistic finding the characters and to put a diagnosis, a presumptive one, between the benign tumor to malignant tumor. And it is very important to know how it's the correct treatment. It depends the benign tumor or malignant tumor lesions. We will discuss about osteochondroma first. The osteochondroma is the most frequent benign tumor. Half of the benign tumors are represented by osteochondroma. There are multiple forms. It exists some forms with multiple osteochondroma lesions that are represented by osteochondromatosis. Where is the localization? The most frequent, it is represented by the metaphyseal area of the long bones near the growth cartilage, for example, to the distal femur. What's the age? In the most frequent cases we have in the decade 2. There doesn't exist predictive for female and male. It is equal for that type of lesions. On the X-ray, you will see a well-defined tumor because it is a benign one with an irregular contour in some cases, like a pedicular one, like in that image in the proximal part of the femur, but with a normal bone density and a very good definition between the normal bone to the abnormal bone. In most cases, it is sessile lesion. On the histopathological examination, you will see a coralliform appearance, hard texture that contains a chondroidal substance. It is a chance that that type of lesion in less than 100% to transform in a malignant tumor, and it is very important to treat correct that benign tumor to prevent for that complication that could transform in a malignant tumor. What's the correct treatment? The correct treatment is just surgical in that cases. The resection at the base of the implantation of the tumor, it is enough. You will have to make a resection here in the normal bone tissue, and that's all right. That's okay in our evolution. That's some examples for osteochondroma. Here we have an osteochondroma proximal to the femur, that's the laser trochanter, and here we have the osteochondroma. That's the other example of the proximal part of the tibia, and that's an intraoperative view of that tumor after we have had the resection. Other frequent tumors are represented by the giant cell tumor. The name for that type of tumor are osteoclastoma or myeloplax tumor. It is the giant cell tumor. It is a borderline tumor because it has 3 stages, and it is very important to make a biopsy and then to make the surgical treatment, because you have to know how to treat that kind of lesion, because if it's an inactive type of giant cell tumor, it is a treatment. If you have an active or aggressive one, the aggressive one is equal to a malign tumor, and it is very important to make a correct treatment. You have to put quickly the diagnosis of inactive tumor, because could transform in active one anytime, and it is very important to make that correct diagnosis. Sorry, for one moment, please. Sorry, can you hear me now?
Yes.
Sorry. The localization of that type of giant cell tumors are represented by the epiphyseal or metaphyseal epiphyseal, in most frequent in the part of the knee, even it's a distal part of the femur or the proximal part of the tibia. The age that are affecting that type of tumors are represented 20 to 40 years, and it is most frequent in female than in male. Doesn't have a specific clinic presentation. All the types of the benign tumors have have the clinic investigation, have the clinic appearance common, and the malignant one are common too. The X-rays, you will see the septic osteolysis, the soap bubbles that we have discussed, like in that image of the fibula. You can see very good the soap bubbles. The deforms of the breaks of the cortical bones, if you have a break of the cortical bone, you will have to know that in most cases we have there malign tumor, benign one, giant cell tumor, an inactive one that has transformed in an active or aggressive one, and it is very important to know. You can see here a giant cell tumor, okay, an inactive one, and you can see here a aggressive one. We have the peristome that are interrupted by the tumor. That means it is an extracompartmental tumor. That means it is no more a benign tumor. We have transformed the benign tumor in a malignant tumor, the inactive one in the aggressive one. What's the histopathological aspect? It is the soft tissue, reddish brown island of bone tissues with intratumor hemorrhage. It is very important that reddish brown and intratumoral hemorrhage that we are seeing on the histopathological examination. What's the correct treatment in that cases? In all cases of giant cell tumors, the correct treatment are represented by the surgical treatment according to the histopathologic type. It is very important to know if it's an inactive one and you have just to make curettage and fill in with graft, with bone grafts, the lesion, but in the active one or in aggressive one, you have to make that surgical type of intervention that are represented for the malign tumor. That means the resections and reconstructions. That's an example for aggressive tumors of the giant cell tumors, the aggressive one. That's another example for an inactive giant cell tumor. You can see the preoperatory image, the anterior view and the lateral view, and then you can see very good the anterior view of the knee and the lateral view of the knee with bone grafts. We have done the curettage of all the lesion, all the tumor, and then we are putting some grafts, allografts, homografts. Doesn't matter what types of grafts are you using, but it is very important the type of treatment, curettage and grafts. Other type of example of curettage and then putting the cement like a cement spacer then on the bone lesion. That's another example for a metabolic active one, active giant cell tumor. You can see here that it is arched structure of the periosteum, and then we have make a resection here, and we have put a graft here and have stabilized that graft with a plate and screws. That's an example for the aggressive one that we have to goes from the normal soft tissue to make the resection, to respect the oncology type of resection. Yes, could be a big one, like in that image. You can see here we have a soft tissue invasion, and it is very important to put that diagnosis, because that giant cell tumor, it is transforming the aggressive one, and we have to make a radical surgical intervention. The bubbles soap aspect, the big osteolysis, you can see on the X-ray, but that type of the lesions you can see very good with the hemorrhage here. You can see very good after the resection. That's the aspect of the cyst, okay, the bubble soap aspect, the big of a big osteolysis. Other type of fragment bone tumor are represented by the essential bone cyst. It is a benign tumor with liquid content. The localization, the proximal metaphyseal, the humerus, rarely on tibia, femur, or calcaneus. It is on the children's, it is most frequent than the adults, and it is most frequent in female in comparison with male. You can make the X-ray to see the lesion, but to make an MRI or a CT scan to establish the criteria of the lesions of the maligned or benign bone tumor. What's the correct treatment? Spontaneous healing after fracture. It is very important that if we have in that type of bone tumor, it is a benign one, and if it's appeared a fracture, it will goes our liquid from the tumor, and then could appear the spontaneous healing after the fracture. What's the most frequent and gold standard treatment for that type of tumors are represented by the membrane curettage and filling with grafts, because you will have their big osteolysis, and to prevent fracture, you will have to put their grafts, even if it's allografts or holografts. That's an example of a humerus bone cyst, a big one with a fracture, and that's a calcaneus localization of cyst bone tumor without any fracture. The correct treatment for that is to go here and to make a very good curettage of the membrane, and then to put grafts there. That's another example for a big bone cyst, benign one, that we have fracture because of the dimension of the tumor. That's another example for osteosynthensis after a bone cyst, that it appear a fracture on the femur because of the abnormal bone. Other frequent tumors are represented by osteoid osteoma, and it is less than 10% of all the benign tumor. It doesn't have a very specific localization, could be anywhere, but in most cases it is on age of decade 2 of the life. It is most frequent in male in comparison with the female, and it is very important to know that it exists a lesion here. We have a big osteolysis on the periosteum, and inside of that osteolysis it exists a lesion, osteocondensation lesion, that it exists there, a nidus, that are round oval, well defined, and it is specific for that type of tumor. The treatment, it is very important, the surgical resection and osteoplasty, but it is very important to put away that nidus. If you are putting the nidus back to the bone after you are making the incision, it isn't correct, but because you will have the recurrence in all cases, and it is very important to remove the nidus. That's another example for that round ovular osteolysis with a small osteocondensation, the nidus. That's an aspect of osteoid of the femoral neck of in a patient. Okay, other type of benign tumor are represented by enchondroma. The localization could be anywhere, but in most frequent cases are localized on the short hand and foot bones, but could appear also on femur or humerus. But in most cases, we are on the short bone of femur and hand. Doesn't have a predilective part for male or female, it is equal. And it exists a pathology. The name of that pathology, it names Ollier disease, and we will discuss this, that multiple osteochondroma that could appear in many bones, and it goes for develop big tumors that in most cases are we are not able to remove all that type of tumors. You will see the characters for benign tumors on X-rays. On the histopathological visualization, you will see white, blue, elastic consistency. On the microscopic conjoined substance are the most frequent in enchondroma. The treatment are specific for the benign tumors, are curettage and filling with bone grafts. That's an example for that type of tumor that has the localization in the center part of the diaphysis of the shaft of the femur. You will see here a osteocondensation lesion. It is not very good defined and have that aspect with osteocondensation with small osteolysis. That's another example in metacarpal bone for that type of tumor. Other type of benign tumor are represented by the fibrous dysplasia that are a benign tumor. It is has a congenital disorder without family characters. They represent, like in enchondroma, that could be twofold and polyostic, but in that form of polyostic could appear the cutaneous hyperpigmentation, then precocious puberty, and that means it will make a syndrome. If you have many lesions on the bones with that cutaneous hyperpigmentation and precocious puberty, will make a syndrome that the name for that type of syndrome is Albright. What's the X-ray that you can see for that fibrous dysplasia are represented by the single or polyostic osteolysis, but well defined because it is a benign tumor, blown cortical bone, septal bone, and islands of bone tissue without periostal reaction. You will not see in any case of fibrous dysplasia the periostal reaction. That's the sign for a malign tumor. What's the correct treatment for that type of tumor are represented like in all the types of benign tumor, and we are not speaking the exception, the active one like in giant cell tumors. We are speaking just for all the types of benign tumors, the surgical curettage and filling with grafts and plus minus fixation. That depends of the dimensions of the tumor. Other type of the tumor are represented by the osteoma. A rare benign tumor are in young patients, are specific for male but could appear in female. And for X-ray, you will see low tumor sessile base with normal bone density, and you will see very good the transition between the abnormal soft tissue and the normal soft tissue. What's the correct treatment? The surgical one, curettage, and filling with grafts. If you have questions, can you hear me?
Yes.
Do you have any
Yes,
questions?
I can hear you.
Please. Okay, if you don't have any question, we will see tomorrow for the malign tumors. It's okay?
I have a question just regarding the hospital, because I know we started late today.